busy in the lunch area. By the time it's already time, let's start the session. I would like to invite Dr. BHARANI KUMAR Reddy to speak on medical management of glaucoma.
Good afternoon, everyone. I was given a very tough topic, not a wide topic in the sense, so that I have to cover everything in a very short time. That the topic is medical management of a glaucoma. Slides are not moving. Once glaucoma is suspected, then confirmed and fitted into one of the subgroups, and if you decide that the treatment has to be started to prevent progression of a disease, probably the medical treatment is the one option, probably the first option, especially in the Indian scenario, but in Western countries, the options are changing. And to prevent glaucoma-related damage, the most viable option is to decrease and stabilize IOP, and we have to treat the systemic conditions that compromise the blood supply to the optic disc. Factors that must be considered before initiating treatment is the stage of the disease, the effectiveness and the problems caused by our treatment, and also the socio-economic factors. These are the anti-glaucoma medications in our armamentarium. All of us are quite aware of it. These two RHO kinase inhibitors are the recent addition to it. And some of the practical points as far as these medicines are concerned is beta blockers, they should be avoided apart from asthma and bradycardia, which already we know. They have to be avoided even in normal tension glaucoma as well as in neonates, and especially if the patients are already on systemic beta blockers. Prostaglandins, they have to be avoided in inflammatory glaucomas and especially in unilateral glaucoma. Brimonidine we have to avoid in extremes of age, as they can cause a delirium in adults, in the elderly people, and apnea in children. And these are the various modes of delivery of drugs, right from topical solutions, which are very old, still the most popular method, to the recent ring inserts and also the anterior chamber implants as far as bimetoprost is concerned. And once sometimes if we encounter a very high pressure situations, especially above 40 or 50, first of all, we have to bring down the pressure to the levels of 25 by using systemic medications. Then only the topical medications will be effective. And especially if you are starting the case for the first time, we have to do a diurnal variation if it is feasible, especially this is possible in a medical college setup at these timings. The idea being to note the peak IOP, the IOP fluctuation, as well as the timing of the IOP spike. The peak IOP, the importance of peak IOP is, it is from this level our target IOP will be decided. And we have to record the baseline IOP as well as the baseline visual fields also on the file for a subsequent follow-up. We all know that the target IOP has to be set in. We all know the definition of target IOP. These are the factors on which our target IOP will depend on: the stage of glaucoma, the rate of progression during our follow-up, and also the risk factors, most important. And target, as a general rule, as far as the target IOP is concerned, in any established case of glaucoma, especially in the mild disease, the IOP always has to be kept below 18 millimeters, and the peak has to be less than, and between the fluctuation should not be more than 3 millimeters. That is also most important. Usually, generally, the visual fields will not progress, especially in advanced cases, if the IOP is maintained around 12 or less than 12. Let us take three scenarios. One is a mild disease wherein there are disc changes but no field defects. Our aim is to keep the target IOP 20% reduction from the baseline, at least 18 millimeters. The moderate disease, wherein disc changes but field changes are confined to one hemifield only. Our aim is to reduce the pressure by 30%, set around 15 millimeters, so that the disease will not progress. And in a very severe disease, wherein you will see the field defects on both hemifields, and it has involved the central 5 degrees also, our aim is to reduce the pressure by 50%, and better to set it around 12 millimeters. And if you are starting the case for the first time, especially, we have to take these factors, especially while selecting the medication. It depends on the systemic comorbidities, the caste, the lifestyle of the individual, and the amount of pressure which we want to reduce. For example, if you want a less pressure reduction around between 2 to 3.5 millimeters, choose betaxolol or bimodine or riposidine. If you want moderate pressure reduction between 3 to 5 millimeters, choose carbonic anhydrase inhibitors or timolol or netarsadil. More pressure, more than 5 millimeters, choose prostaglandins. Prostaglandins are choice for the glaucoma specialist being they will take care of the nocturnal spikes also, especially which is very difficult to measure, especially during our routine practice. If one drug which have selected is not working, you can go for other drugs. So many drugs are available. How to initiate the therapy is we have to select a drug which will have a potency to at least 20% efficacy to decrease the pressure, probably prostaglandin or beta blocker, and we have to continue the drug for a period of 4 to 6 weeks before deciding to change the drug or to continue the drug. Especially the best is to take a preservative-free medication so that we can avoid the future damage. After 4 to 6 weeks, if possible, we have to do a diurnal control also. The idea is to check the IOP reduction as well as the fluctuation also is most important, which we have to end. At the end of 4 to 6 weeks, if the primary drug is acting and it has achieved the target IOP, continue the drug, no problem. Whereas, if the drug fails to achieve at least 20% reduction or the initial drug has resulted in some sort of a side effects, then switch to another drug. Whereas, if the primary drug has achieved 20% reduction but not achieved the target IOP, you can add the another drug. Suppose one advantage of prostaglandins is intra-class switch is possible, which is not possible with other group of drugs. For example, we have to be aware of this so-called washout phenomenon. That means the initial drug continues to act for a certain period of time, even after stopping the treatment. That is for 3 days for pilocarpine, 6 weeks for beta blockers. These are the rules for combination therapy. And follow-up is once the IOP is achieved, target IOP achieved, it's sustained for 3 to 4 months with no further field loss. Follow up for 1 to 2 years at 3 to 4 monthly intervals, and then at 6 monthly intervals. We have to advise them not to drink large quantity of water, especially in the advanced cases. We have to simultaneously monitor the systemic conditions also. Blood pressure should always be maintained as per age. Don't allow hypotension to develop. If 2 drugs are not acting, we can add other drugs. Nowadays, even 4 drugs are being tried, especially if the patient is not fit for surgery. A word about neuroprotection is, as now we know the definition of glaucoma is neurodegenerative disease. The death is being caused by apoptosis. We can try these neuroprotective agents. And word about normal tension glaucoma is, this is more common in people with primary vascular dysregulation syndrome. We have to manage this condition. Avoid beta blockers. We can try any other drugs, but don't use beta blockers. And coming to subtypes of glaucoma, pigmentary glaucoma, we can try myotics, especially if the patient is able to tolerate, and prostaglandins also can be tried. Angle recession glaucoma, we can try prostaglandin, carbonic anhydrase inhibitors. Pseudoexfoliation glaucoma, especially prostaglandin analogs are found to be best one. Steroid induced, you can try anyone. PACG, especially pilocarpine before laser iridotomy. Congenital glaucoma is basically a surgical disease, but one can try medicines, especially beta blockers not advised. Beta blockers and brimodin we have to avoid as they can create problems in children. The best choice is topical carbonic anhydrase inhibitors. Inflammatory glaucoma, avoid pilocarpine and prostaglandins. Carbonic anhydrase inhibitors are the best choice. In lactating and pregnant women especially, as most of the drugs are category C, uncertain safety. And we have to avoid carbonic anhydrase inhibitors because in the long run they can cause teratoma. Prostaglandins, they can induce a premature labor. Brimodin and beta blockers we can use up to 8 months of pregnancy. After that, they have to be stopped. The best thing in pregnant women is to do a laser selective trabeculoplasty. Are the medical therapy completely safe? In long term, especially if you use the drugs over a period of 1 to 2 decades, they can cause conjunctival cicatrization that can ultimately lead to dry eye, and also the subsequent surgery will be a failure. Regarding medical legal issues, not warning the patients about side effects of the drugs is the most common cause for medical legal issues, and failure to educate the patient and family also is one of the causes. Thank you.
Thank you, sir. It was a great talk. I think in 7 minutes it is a marvelous job to finish.
It is a 40-minute talk, madam. I have to condense to.
So I think I revised my whole medical management. Thank you so much. So just as a student, I wanted to ask you, like in medical management, after using 4 drugs, So how long do you keep on 4 drugs, sir? If the patient, like what are your indications if
So
you want
actually,
to go
4
in
drugs
for
are
the-
indicated when the patient is not fit for surgery, madam.
Okay.
Usually, the basic definition is once it is not effective with 3 drugs, indication is surgery only.
Okay, okay, sir.
4 drugs are tried only in situations when the patient is not fit for surgery.
Okay. Thank you, sir. Thank you so much.